Welcome to the third module of the Musculoskeletal exam series. This module will focus on the physical exam of the foot and ankle. You want to accomplish 3 tasks in the physical exam of the foot and ankle. Look, feel, and move. If you can accomplish these 3 tasks, then you will have a pretty good idea of the physical condition of the foot and ankle. Throughout the physical exam, we are evaluating 6 anatomical features: the skin, vascular system, nerves, muscles, joints, and bones. First, begin with the look or inspection component of the exam. Inspection begins when the patient walks in the room. You want to observe their gait for any asymmetry, such as seen when a patient tries to prevent weight bearing on an injured foot, or if there is any abnormal contact with the ground, such as in foot drop. Note whether the gait is heel to toe, which is the normal gait pattern, flat foot, or toe to heel. Gait that is toe to heel, which is premature foot loading, is seen in equinus contracture, which is the excessive contraction or spasticity of the gastroc-soleus complex, preventing dorsiflexion. You want the patient to remove their shoes and socks to examine the surface features of the foot and ankle from all 4 sides standing and then supine. While the patient is standing, you are assessing the alignment of the toes and the relationship of the forefoot to the hindfoot. From the anterior view, you want to look for the presence of a hallux valgus, more commonly known as a bunion, the presence of any hammer toes, or any other deformities such as club feet or metatarsus adductus, which is the #1 pediatric foot disorder. From the posterior view, a normal finding is slightly valgus alignment with no lateral toes visualized. Too many lateral toes seen indicates posterior tibialis tendon dysfunction. From the medial view, you are looking for the presence of pes planus, or flat foot, or pes cavus, high arch. From the lateral view, you want to look for prominence of the posterior calcaneus or the presence of abnormal swelling. With the patient supine on the exam table, assess the plantar view of the foot to look for calluses or ulcers, the latter being especially prevalent in diabetics. You want to assess if there is any swelling or edema, lesions, or noticeable deformities present, and also observe the color of the skin. You also want to look at the patient's shoes. A narrow toe box may be associated with hallux valgus, especially in women, and abnormal wear may indicate malalignment, such as pes planus or cavus, or dysfunction, such as foot drop. Next is the feel component of the exam. You are going to palpate the foot and ankle for abnormal swelling or tenderness. Structurally, the foot has 3 main parts: the forefoot, midfoot, and hindfoot. The forefoot consists of 5 phalanges and their connecting long bones, the metatarsals. Each phalange has 3 bones except the first phalange, or the big toe, which only has 2. Phalangeal fractures are common injuries incurred from stubbing a toe or dropping something on a toe, with most being benign and rarely is surgical treatment needed. The first metatarsal phalangeal joint is the most common site of gout, so the patient will have redness and swelling in this region if gout is present. Metatarsals are commonly fractured in runners. The first empty head is also prominent and painful when hallux valgus or a bunion is present. The midfoot includes 5 irregularly shaped tarsal bones: the navicular, cuboid, and the 3 cuneiform bones. The cuboid and cuneiform bones articulate with associated metatarsals. Each have an individual joint capsule, but are also wrapped in one big joint capsule to form the tarsometatarsal joint, which is also known as the Liz-Frank joint. The talonavicular and calcaneo-cuboid joints form the transverse tarsal or the mid-tarsal joint proximally, which allows for foot abduction and adduction. Tenderness in the midfoot region suggests fracture, osteoarthritis, or dislocation. Of note, Lisfranc fractures or dislocations are commonly missed injuries that may occur from a seemingly trivial event like a misstep into a hole with axial compression or abduction force on a plantar flexed foot from a misstep walking downstairs. The hind foot, consisting of the calcaneus and talus, links the midfoot to the ankle. The tibia and fibula articulate with the dome of the talus to form the ankle joint, which primarily provides dorsiflexion, which is true extension, and plantar flexion, which is true flexion. The talus articulates inferiorly with the calcaneus via 3 facets, forming the subtalar joint, which allows for inversion and eversion as well as rotation of the foot. The floor of the subtalar joint is supported by the spring ligament. The plantar fascia originates on the calcaneus and supports the longitudinal arch. Pathology here causes inflammation, with associated tenderness upon palpation. Plantar fasciitis, the most common cause of heel pain in adults, is twice as common in females and is associated with obesity. You will also want to palpate the malleoli, with the lateral malleolus of the fibula and the medial malleolus of the tibia. Pain and or swelling localized here is indicative of a fracture or sprain. When palpating the soft tissues, you want to note if the skin feels cool to the touch or if there is any swelling present. You want to palpate the area around the medial malleolus for the medial ankle ligaments, collectively called the deltoid ligament, and the tendons passing posteriorly and inferiorly, which are the tibialis posterior, the flexor digitorum longus, and the flexor hallucis longus tendons. The lateral ankle ligaments consist of the anterior talofibular ligament, the calcaneofibular ligament, and the posterior talofibular ligament, which all insert on the lateral malleolus. Pain here suggests an ankle sprain. The ankle is the most injured joint of the body, with ankle sprains being the #1 MSK injury. Inversion is the #1 mechanism of injury, especially with the foot in plantar flexion, where it is much less stable than when it is in dorsiflexion. The ATFL is the #1 injured ligament in ankle sprains, and the CFL is the second most injured ligament in ankle sprains, whereas the PTFL is rarely injured. The peroneal tendons also pass posterior and inferior to the lateral malleolus, and you will want to palpate for these as well. The Achilles tendon inserts on the posterior aspect of the calcaneus and is major in plantar flexion. The low blood supply to this tendon makes it prone to chronic injury. Pain and tenderness upon palpation suggests tendinitis, and a defect here suggests Achilles rupture. The distal tibiofibular syndesmosis is the primary support of the ankle and consists of 4 ligaments. If the syndesmosis is torn, the ankle mortise is disrupted, and the fibula with the firmly attached talus will displace laterally. 2 pulses palpable in the foot are the posterior tibialis artery, found posterior to the medial malleolus, and the dorsalis pedis artery, lateral to the extensor hallucis longus tendon. The final task of the physical exam is the move portion. Range of motion can be examined passively, where movement of the joint is done by the examiner, and actively, where movement is done by the patient. It is important to do both, because if there is decreased active range of motion compared to passive, this can indicate a functional deficit may be present due to injury or other pathology. There are 4 main motions that occur at the ankle complex, which is the ankle and the subtalar joints collectively, that you want to test. First, stabilize the subtalar joint. Normal range of motion for passive dorsiflexion is about 20 degrees, while normal plantar flexion is about 50 degrees. Next, you want to stabilize the tibia. Normal passive inversion is about 5 to 10 degrees and eversion is about 5 degrees. Range of motion should always be compared bilaterally and any deficit should be noted. The range of motion of the foot can also be tested. Resistive range of motion should be tested to assess for any muscular weaknesses or injuries. When testing for muscle strength, you want to isolate the muscle of interest by positioning the joint to exclude other muscles that have the same activity. For example, there are 4 muscles that can dorsiflex the foot. When the strength of the anterior tibialis muscle is assessed, which is the best muscle to test the L4 nerve root function, you want to place the foot in dorsiflexion and inversion, and then ask the patient to pull the foot into more dorsiflexion while concurrently flexing the toes to eliminate the activity of the extensor hallucis longus and extensor digitorum longus muscles while you provide resistance in the opposite direction. Special tests can be performed, and these are used based on the history or earlier findings during the physical exam. A set of special tests is provided. Special tests from this list can be utilized to diagnose and localize an injury. For example, if earlier during the inspection phase of the physical exam you observed too many lateral toes from the posterior view of the standing patient, the heel rise test can then be utilized to assess posterior tibialis tendon dysfunction, which is the most common cause of acquired flat foot in adults. Provided is a list of the resources utilized in this presentation. A video of the physical exam, all the special tests, and a PowerPoint of the radiology of the foot and ankle will also be made available for viewing.